Hello and welcome to Module 12, Applying Trauma-Informed and Trauma-Specific Services. In Module 11, we grounded ourselves in the foundations of trauma-informed care, the ACEs research, the paradigm shift from what is wrong with you to what happened to you, and SAMHSA's 6 core principles. We established that trauma-informed care is not a technique, but a philosophy, a way of structuring systems, relationships, and practices so that they do not reproduce the conditions of harm that trauma survivors have already experienced. This week, we go one step further by making a distinction that is essential to clinical practice, but often muddled in professional conversation: the difference between trauma-informed care and trauma-specific services. These are not interchangeable terms, and confusing them has real consequences for how systems are designed, how clients are assessed, and how treatment decisions are made. Understanding the difference is one of the most practically important things you will take from this module. By the end of this session, you should be able to clearly distinguish between trauma-informed care and trauma-specific services, and identify at least 2 evidence-based, trauma-specific interventions. Let's start with the distinction itself, because while it sounds simple, it carries significant implications. Trauma-informed care is an organizational and relational orientation. It describes how a system, an agency, or a practitioner engages with anyone who walks through the door. It is built on the recognition that trauma is prevalent, that its effects are pervasive, and that any person seeking services may have a trauma history, whether disclosed or not. Trauma-informed care does not require a formal trauma diagnosis. It does not require a specific treatment protocol. It requires a commitment to creating environments and relationships that are safe, trustworthy, collaborative, empowering, and culturally responsive, so that care is not inadvertently re-traumatizing, regardless of why the person is there. One of your video resources this week illustrates this with clarity. Trauma-informed care is about the culture of the organization, the way staff interacts with each other and with clients, the way intake processes are structured, the way policies and procedures are designed. It is not one thing a clinician does in a session. It is everything an organization does at every level that either replicates harm or disrupts it. Trauma-specific services, by contrast, are targeted clinical interventions designed specifically to address trauma symptoms and traumatic stress reactions in individuals who have a known trauma history and are experiencing significant impairment as a result. They are treatment protocols, structured, evidence-based approaches that are applied to clients with identified trauma-related needs, typically after assessment has established the nature and extent of those needs. They require a higher level of clinical training and expertise, and they are applied intentionally and purposefully rather than universally. The relationship between the two is not either-or, it is both and. Your reading from SAMHSA Tip 57 makes this explicit. Trauma-informed care creates the environment within which trauma-specific services can be effectively delivered. Without trauma-informed care, even the most technically skilled trauma-specific intervention may fail, because clients who do not feel safe, respected, and understood are unlikely to engage in the vulnerable work that trauma treatment requires. And without trauma-specific services, trauma-informed care alone may be insufficient for clients with significant, persistent trauma-related symptoms. The video resources this week collectively explore the relationship between trauma-informed care and trauma-specific approaches from multiple perspectives, helping to build a cohesive understanding of how they differ and work together. They clarify the conceptual distinction between the two, using concrete examples to highlight differences in scope, target, and application, while also emphasizing the core principles of trauma-informed care, and how recognizing the impact of trauma fundamentally shifts the way professionals engage with clients. Importantly, they underscore that trauma-informed care is not a specialized clinical technique, but a universal orientation that should guide all interactions. Together, the videos also highlight that becoming trauma-informed is not a one-time training, but an ongoing cultural shift within organizations, one that requires leadership commitment, staff support, and the integration of trauma-informed values into everyday practices. This perspective directly connects to your assignment, which asks you to examine SAMHSA's framework alongside other treatment models and identify shared core principles. Those shared elements emerge at the intersection of trauma-informed philosophy and trauma-specific techniques, reflecting the foundational principles that underlie effective trauma treatment, regardless of the specific approach used. Now, let's look at some of the trauma-specific interventions that the literature supports, because naming and understanding them is part of your learning objective this week. Trauma-focused cognitive behavioral therapy, or TF-CBT, is one of the most extensively researched and widely used trauma-specific interventions, particularly with children and adolescents. Your suggested reading this week examines its implementation in a child and adolescent mental health setting, showing significant improvements in PTSD symptoms and overall mental health outcomes. TF-CBT is a structured, time-limited approach that combines trauma processing with cognitive restructuring, psychoeducation, affect regulation skills, and family involvement. It is delivered in parallel with both the child and a supportive caregiver, recognizing that the child's healing occurs within the context of their most important relationships. Prolonged exposure therapy, or PE, is a cognitive behavioral treatment developed by Edna Foa and her colleagues, with the largest evidence base of any trauma-specific intervention for adult PTSD. It involves two primary components: in vivo exposure, gradual, real-world confrontation with trauma reminders that have been avoided, and imaginal exposure, which involves repeated, structured revisiting of the traumatic memory in session. The mechanism is habituation. By activating the fear structure in a safe context, the threat response gradually extinguishes, and the memory loses its power to generate the same level of distress. Cognitive processing therapy, or CPT, focuses on identifying and restructuring the stuck points, distorted beliefs about the self, others, and the world that develop in the aftermath of trauma and maintain post-traumatic distress. It has been validated across military, sexual assault, and other civilian trauma populations, and as several of you may have explored through the Module 8 assignment, it can be highly effective, even for clients who are not yet ready for direct exposure work. Eye movement desensitization and reprocessing, or EMDR, developed by Francine Shapiro, uses bilateral sensory stimulation, typically guided eye movements, while the client holds a distressing traumatic memory in mind. The theoretical mechanism is adaptive information processing. The bilateral stimulation is thought to facilitate the brain's natural processing system, allowing traumatic memories to be integrated more adaptively. EMDR has a substantial evidence base and is recommended by multiple international treatment guidelines, including the WHO. Seeking Safety, which we encountered in Module 4, is a present-focused intervention designed specifically for clients with co-occurring PTSD and substance use disorders. Its emphasis on stabilization rather than trauma processing makes it particularly appropriate for clients in early recovery or those who are not yet ready for more intensive exposure-based work. Each of these interventions has specific indications, specific populations for which the evidence is strongest, and specific prerequisites in terms of client readiness and clinical setting. Knowing them by name and understanding their mechanisms is essential preparation for clinical practice. I want to return now to something your module introduction raises that deserves attention: the role of culture, ethnicity, race, and social class in shaping both trauma and treatment. This is not supplementary to the discussion of trauma-specific services, it is central to it. The evidence base for most trauma-specific interventions was built primarily on studies conducted with white, middle-class, English-speaking populations, particularly in the early decades of trauma research. This has changed significantly, and the field has made meaningful progress in adapting and validating interventions across diverse populations. But the practitioner who applies a trauma-specific intervention without attention to the client's cultural context, their experiences of racialized trauma, or the ways that class and immigration status shape both their symptoms and their access to care, is providing incomplete treatment. What your assignment this week asks you to do is precisely the clinical thinking that bridges the gap between evidence-based protocols and culturally responsive practice. The intervention tells you what to do. The intersectional ecological lens tells you with whom, in what context, with what adaptations, and within what larger system of care. Your reading on implementing trauma-informed care notes something important. Even when organizations are committed to trauma-informed principles, there is significant inconsistency in how those principles are defined and operationalized in practice. That inconsistency is often most pronounced when it comes to cultural responsiveness, the difference between saying that equity and cultural humility are values and structuring actual practices, hiring decisions, and community partnerships in ways that embody those values. This is the work that social workers at every level of practice, clinical, administrative, and policy, are called to engage. This week, we began by drawing the essential distinction between trauma-informed care and trauma-specific services, two complementary but different levels of response to trauma. Trauma-informed care is a universal orientation, a philosophical and organizational commitment to creating environments that do not reproduce harm. Trauma-specific services are targeted clinical interventions, structured, evidence-based approaches applied to individuals with identified trauma-related needs and symptoms. We examined how these two levels work together and why the absence of either creates a gap. Trauma-informed care without trauma-specific services may leave significant clinical need unmet. Trauma-specific services without a trauma-informed organizational culture may fail because the client never feels safe enough to engage in the work. We identified specific evidence-based trauma-specific interventions, TF-CBT, prolonged exposure, CPT, EMDR, and seeking safety, understanding them not as interchangeable, but as distinct approaches with distinct mechanisms, evidence bases, and indications. And we return to the intersectional and ecological lenses from Modules 9 and 10, recognizing that any trauma-specific intervention must be delivered with attention to the full social and cultural context of the client. Because trauma does not occur in a vacuum, and treatment cannot be effective if it ignores the context that shaped the trauma. This module is the practical culmination of everything the course has built. The frameworks, the skills, the self-reflection, the systemic thinking, they all converge here, in the moment of clinical decision-making. What does this person need, in this context, at this stage of their recovery, and what can I offer that is both evidence-based and genuinely responsive to who they are? That question is the practice of trauma-informed social work, and it is a question you will keep asking and refining your answer to across your entire career.